So, Dr. Enrico, thank you for joining in. I know since there was some emergency, so we have a good crowd, and we have done a basic priming of what the concept of cord blood transfusion is. So, I think now the crowd is ready to have some global perspective from you. So, we'll request you to please take your slides and take it further. The stage is yours. Thank you.
Thank you. Are you seeing my slides?
Yes, we can see your slides.
All right. So first of all, again, I very, very much apologize, but I had an emergency I had to attend. So very sorry for that. Okay, so my presentation will be on the scope and the present status of cord blood transfusion in newborns. And I think you just heard I'm a neonatologist, so I work in a neonatal intensive care unit. How does it go from there or like this? And what is important for you to know, I don't know if there are neonatologists in the room, but we use a lot of blood transfusions in our NICU, and this is the same all over the world, especially if the babies are born very preterms. This is the number of the percentage of preterms below 32 weeks needing a red blood cell transfusion. So it's almost half of them. It's less so with platelets. And if you look at extreme preterms, so those are babies below 28 weeks, almost all of them need a red blood cell transfusion before discharge, and most of them need several blood transfusions. And why do we give red blood cell transfusion? Well, this, of course, is something that you all know. Red blood cells contain hemoglobin, and hemoglobin is essential to transport oxygen to the various organs. That's why we need red blood cells. And we have always thought that red blood cell transfusions were good. There were mainly pros associated with transfusion, because it would improve the tissue oxygenation. It's especially a lifesaver in case of hemorrhagic shock. And especially in premature babies, we thought that it would help them to gain more weight and have less problem, for example, like apneic incidents. But more and more in the past few years, we have understood that there may be also cons, and that these cons are maybe more of a problem than we initially thought. And one of the most important one is inflammation. And inflammation in extreme preterm babies can concern various organs. And we see in babies that are born very preterm, various organs that suffer from inflammation. For example, the bowels, and it can lead to necrotizing enterocolitis, and sometimes it's associated with transfusion, and we call this TANEC, transfusion-associated necrotizing enterocolitis. You can have lung injury, TRALI, transfusion-associated lung injury, and you can have retinopathy of prematurity, ROP, or IVH, intraventricular hemorrhage, or BPD, bronchopulmonary dysplasia. And these are all diseases that occur regularly in very preterm babies, and more studies are showing an association with transfusion. Of course, association does not mean a causative effect, a causal association. This is not yet been proven, but there seems to be a correlation. And if transfusion harm preterm babies, why could that be the case? Why is it so? Well, what is important to know, and I suppose that you all know, is that the adult hemoglobin chains are different than the fetal or preterm hemoglobin chains. We as adults have alpha and beta chains, but the fetal hemoglobin, so actually the hemoglobin of preterm babies, because they are the same as fetuses, contains different chains, not the beta but the gamma. And why is this important? I will explain to you in a second. This is a graph to show you what happens during prenatal and postnatal stage. In the prenatal stage, as a fetus or as a preterm neonate, you have mainly alpha and gamma, and gradually in the last trimester of pregnancy, there is a switch in hemoglobin change with more beta being produced. So when the children are 1 or 2 years old, they already have the adult hemoglobin. But in the preterm life, so when they are at our NICU, their hemoglobin mostly contains the red and the green, not the beta. And the reason it's important is that the hemoglobin of the fetal hemoglobin, or HbF, has a different oxygen dissociation curve. It has a higher affinity for oxygen. What this means is that the fetal hemoglobin preserves the oxygen, whereas more easily, whereas adult hemoglobin releases the oxygen more easily. And that's very important, and it's good that it's like this, because that's the way oxygen is transferred from maternal blood to the fetus across the placenta. So it's a good thing when oxygen from the mother is bound to the hemoglobin of the mother, adult hemoglobin, it transfers to the fetus because the fetus has a higher affinity to the oxygen. So that's a good thing. The problem is that when you give a transfusion to a baby, which has a premature baby, like in this picture, which has mainly at birth 90% fetal hemoglobin, and you give a transfusion with adult red blood cell, because that's what we do all over the world, what happens is that you dilute the hemoglobin of the baby from fetal hemoglobin to adult hemoglobin. After a couple of transfusions, the circulating blood volume of that baby changes from fetal hemoglobin towards more adult hemoglobin. And this adult hemoglobin, as I explained before, releases more easily than we would like oxygen to various organs. And this release of more oxygen can lead to oxidative stress and more free radicals, because babies are not, preterm babies don't know how to deal with that excess of oxygen, and this can lead to inflammation. And various studies in the past 10 years have shown an association with lower fetal hemoglobin after transfusion, with a higher risk of various diseases, including retinopathy of prematurity and BPD. So those babies that received more transfusion had a lower HbF, and those babies with a lower HbF had more inflammation of the retina and more inflammation of the lungs. Of course, that's not the real way to, the best way to find if there's a causal association. So we'll come that point in a second. And what has been suggested in the past decade is that maybe we're giving to this baby the wrong blood, and we should give to the baby's blood from containing mostly fetal hemoglobin. And this is blood that is can be found, for example, in the placenta, like in this picture. A placenta from a baby contains a lot of blood and contains mainly fetal hemoglobin. And this has been suggested in many papers that cord blood transfusion might be better for preterm babies in the NICU. Might be better. We need to show this in randomized trials. And we are very fortunate that just this week, the first trial has been published. And this is the evidence that we need. The first trial has been published, and I will discuss this trial with you, the results. And of course, this is just one trial. We need more trial. This is just a first small trial. We need more and larger trial before we can reach definitive conclusion. This trial has been performed in Italy, and the first author of this paper, is the pioneer in the field of cord blood transfusion. It's Luciana Teofili, which you can see here in the picture. She's a hematologist, and she works for all her career with transfusions in Italy, and she has performed this trial with all her Italian colleagues because it was a multi-center trial in Italy. This trial was performed between 2021 and 2024. So it took 3 years to perform this trial. And they included 145 preterm babies delivered or born before 28 weeks of gestation, between 24 and 28 weeks. So those were extreme preterm babies. Half of them were randomized to receive adult red blood cells, and half of them were randomized to receive cord blood. At the end, during the first couple of days or weeks, there were several deaths. So 56 of these patients could be evaluated. And they did an intention to treat in those 56 in both groups. The problem in this trial, they were very honest by describing the problems with the trial, is that unfortunately, they were not able to give the cord blood to all babies included in the cord blood group because they did not have enough cord blood to give to those babies. So there was a protocol violation in many of these children. And at the end of the day, only 38 patients received only adult red blood cells, and only 17 patients received only cord blood, because many of them received either adult and cord blood. That's because they did not have enough cord blood material to give to these preterm babies. So they did several analyses, the intention to treat, as that was the first what they had performed, and then they did an analysis per protocol and analyzing only those babies that received either adult or only cord blood. And I will show you the results. And I will show you the results mainly of the per protocol, because that's the most interesting. As you can see, those are very, the groups are similar, and those are very extreme preterm babies with an average gestational age of 26 weeks and an average weight of around 700 grams. And the main results are as follows. When they looked at the retinopathy of prematurity, that was their primary outcome, none of the babies that received only cord blood had severe retinopathy or retinopathy needed treatment. And this is for a neonatologist, really an incredible result. But again, the numbers are very small. The percentage of retinopathy in the group receiving only adult red blood cell was more or less what we would expect in a group of babies born at 26 weeks. Sorry. Then they looked also at bronchopulmonary dysplasia, and they saw that the group receiving cord blood red blood cells, they had 50% less risk of developing BPD. So that's, again, a very surprising decrease in the risk of BPD. The only difference in these two groups was the type of red blood cell that they received. The group receiving adult red blood cell had a 63% of risk of developing BPD, which is more or less what we would expect in this group. The conclusion is that they suggest that the BORN trial suggests that cord blood transfusion in extremely preterm neonates below 28 weeks has a favorable clinical impact. But of course, this needs to be assessed in larger randomized trial. But this is the first trial, and it's a pioneering trial, and the authors rightly say that this could mean an important change in transfusion approach in preterm neonates. In the same time, they also say that the change not only should be in what kind of transfusion we give in the neonatal intensive care unit, but there should be also a change in the paradigm of cord blood collection, because in many countries, including in our country, cord blood is mainly collected and centered around hematopoietic stem cell transplant use. It's rarely needed, but that's the main reason we collect cord blood in many countries, at least in Europe. But maybe in the future, we should envisage, if the trials show that this is really an improvement in the outcome, to collect the cord blood not only for hematopoietic stem cell transplant, but also for transfusion in neonates. So what is the global situation now at the current time? At the current time, as far as we know, but we are not totally sure, because we need to make to look I don't know what's happening to my slide, but umbilical cord blood at the current time is primarily used for research context, not in clinical practice. Somebody is drawing something on my slides. I don't know what's happening. I hope you can still read it. There have been several safety and feasibility studies with positive results, so that's important, showing that it's safe, there is a low risk of infection, and that it's feasible. And there have been now already a few randomized trials. One is the one I just showed you, and it's just been published last week. And the other one is being currently performed in Spain, but it's not yet been published. What else? A couple of years ago, we started an international umbilical cord blood interest group to share our experience in cord blood research for neonates. And this is a group with 13 centers around the world with 47 participants. And we've had until now 2 meetings. The first one in December 24, in which we first introduced ourselves, the centers, what everybody was doing, and we tried to share our experience and our problems with this cord blood research. And the second meeting in April, we discussed the current programs on clinical trials. Another interest group has just recently started, based from the ISPT, and had a first meeting in August 2025. So with this international cord blood group, we thought about various topics that need to be assessed and addressed further, not only the randomized trials, but also the risk of immunization, of infection, how to improve the collection technique, whether or not these cord blood should be treated the same way and should be irradiated or not, and whether or not you can pool various cord blood together. So I would like to conclude that I think that at this point we are at a turning point in history of neonatal transfusion, and this could mean a very important turning point that could lead to a revolution in the way we are transfusing preterm babies. But before we move to that, we really need, thank you, now the slides look better. We need to join forces together with everyone who is working on these cord blood programs, because we need to share experience with each other, and not that everybody try to invent the wheel on their own. And we need, however, to move faster and move forward better than we're currently doing, because every day now preterm babies are suffering maybe from this transfusion. So there is quite a bit of pressure to try and improve their outcomes. And I think that using cord blood could be a major game changer. I thank you for your attention.
Thank you, Dr. Enrico. It's a full house. I wish you can hear the claps.
Thank you.
There are nearly 80 people who are online. Because of some technical glitch, I will have to, convey the questions and the if there is anything which the crowd has. So I'll open the floor to the chairpersons if they want to ask any question. How do you select these? So one of the questions which they have asked is, do you have a separate selection guidelines from the mothers from whom you'll collect?
We are not yet collecting cord blood, so we don't have a separate guidelines yet. We are going to start next week a feasibility study in the Netherlands, in which we will first ask permission, consent to the parents, and then we will collect the blood for those who do consent. So that's a different consent procedure, but the procedure in itself of collecting the blood is exactly the same as the one from stem cell collection. So the procedure itself is exactly the same.
Sure. Can you ask how are they going to enroll the patient during the antenatal period or at the
for collection?
Yeah.
So another question is that would you like to take this consent and enroll these mothers during the antenatal period, or then coming closer to the delivery? Yeah, you.
Yes. So we need to ask for consent before. So we ask them at 30 weeks of gestation. We currently ask them at that time, so that they have time to think about it, and we have time to make all kinds of tests for viral infections, etc. It needs to be a safe product, so we need to give them time to reflect, and that's so the best way would be already at 30 weeks. But of course, if you don't have the chance and you ask them a couple of days before delivery, that could be good enough. My experience until now is that uh, all mothers, all parents really love to participate in this project. Why? Because we're not hurting anyone. Oh,
Hello.
is there a problem?
Divjot, can you please mute yourself? Divjot, can you please mute yourself? Yeah, Dr. Enrico, please.
My experience in the past couple of years is that parents and midwives really love this project. They think it's really a waste of blood products every time we throw away a placenta. And if you can help research, and if you can help in the future babies by using blood from a placenta that would otherwise be discharged, they all in the current era of recycling and reusing stuff that we can that is available. It's very much in the mind of a lot of young people now. So most of them that are currently delivering really love this project.
Yeah, even in our study where we just presented our validation work, feasibility work, and all the mothers were more than happy to give us consent, although they were very close to their delivery, but they had a thought that, it is anyways going to get wasted. So why don't you use it for some work?
Exactly.
Yeah. Any other questions?
From the online?
For online participants, I will request you to please type in your question. I think that will be easier for us to respond to that. So, yeah. So till that time, we have a question from our delegates in the hall.
Thank you, Dr. Enrico. And Satyam, in fact, last year when we came here, and I was just talking to you because just a few days earlier, and from India, there's a published study from Riva Medical College, and that was published in 2022. And this is a study where they collected around 50 umbilical cord bloods, and and they transfused it very, very easily. So that was done, and in fact, there was no difference, and there was a marked increase in hemoglobin, and that was a significant increase in hemoglobin of babies who were transfused with umbilical cord blood versus those who were with an adult blood transfusion. So the feasibility was there, and I think they are doing further studies in Riva about this. And this is what I asked you last year when I was telling you whether such a thing is happening or not. And I'm so happy that you said there's a multimodal, multi-country proof of concept thing, which around 10 countries have already been shown in your one of your papers. I think this is a way forward, certainly.
Thank you.
For all of
So,
us.
so Dr. Enrico, we had
as a neonatologist, as you were telling, Enrico. So, sir, I was the Secretary General of National Neonatology Forum of India. So, I'm feel privileged that we are partnering with this kind of a symposium or discussions. And I think this generated some kind of enthusiasm, and that is why one of my fellow from Postgraduate Institute of Chandigarh, she asked for whether she can attend. I hope she's attending the meeting online also, so, because I shared her the link also. I hope this has generated a lot of enthusiasm.
Yes. So, Dr. Enrico, we have a former secretary from National Neonatology Forum of India, and we have many neonatologists and pediatricians in our audience, and they were sharing their experience of some of the studies, similar work which are being done at Reva Medical College in central part of the country. So there is a lot of interest in the similar work in India, and a lot of centers are trying to work on it or replicate. And just to keep it on record, from 1996, there are publications of use of cord blood from the eastern part of our country, that is Kolkata, from Dr. Bhattacharya from here. He, I think from there, has published nearly 15 papers from the span of 1996 to 2004. And he have used cord blood not only in neonates, but in malaria, in thalassemia, in congenital heart disease. I think he has one of the most extensive work published even across the world. But yes, a lot of molecular work, hemoglobin F concepts were not there at that time. So we don't actually have that data from his study. Any
So
question from the...
I thank you for your point. And what I try to say, maybe I came across the wrong way. As far as I know, there have not been other randomized control trial in extreme preterms. So I only focused on this use of cord blood in extreme preterms, not in other groups. I know indeed that there have been also studies for congenital heart disease, the use of cord blood for congenital. So those are other groups. For this talk, I only presented on cord blood. And can you ask, because maybe I'm not aware, if there have been in India that I am not aware of randomized trial in cord blood used in extreme preterms?
No, there have been no randomized control trial. There have been some observational studies, single arm observational studies.
Yeah. And are you planning to do a randomized trial in India?
Yes.
Because you told me that you've done a feasibility.
Yes, we have recently completed a feasibility. Now we are submitting our results to go for a phase 1 trial. So our neonatologist is here. So she's equally interested and excited. And I think with your talk, we have got more support to, to go ahead with this trial in coming months or a year.
Fantastic. Good luck.
So we have a dean from pediatrics department. He will ask a question.
Just a query. Do we expect any qualitative or quantitative difference in collection of this placental or cord blood if a mother is delivering as 30 weeks of gestation versus a mother who is delivering as 40 weeks of gestation? Do we expect any difference in the quantity of the collected blood?
So his question is whether the gestation, the period of gestation of the mother, will that influence the volume of cord blood that we are collecting? So that was a finding that we have in our feasibility work, that a primary gravida was, we were able to collect more volume as compared to a multigravida.
So my impression is, and we have now experience with 500 cord blood collection, is that there is a very clear association, especially with the weight of the baby. The higher the birth weight, the higher the cord blood volume, and especially also with the timing of cord clamping. If you clamp the cord earlier, you will have more blood in the placenta than if you wait longer time. Unfortunately, in the Netherlands now, all babies have delayed cord clamping, which is good for the babies, but it's less good for the cord blood collection. But even with delayed cord clamping, and we have term babies delivered by cesarean, which are now always have a 3 minutes delayed cord clamping, even with that, in almost 60% of the cases, we have more than 70 mils of cord blood, which is enough for a couple of transfusions.
Sure. I don't see any question in the chat box, but yeah, there is one more from the hall.
explained what are besides the TTI ciliary activity, any other exclusion criteria are there for selection of the
infectious.
besides the ciliary activity?
So are they testing for something more?
Yeah.
So apart from your routine TTI screening, which you do it for on all donated blood, do you test for something more on the cord blood that you plan to collect?
So apart from the routine, for the viral infections, we also test for parvo-B19, parvovirus, and of course we do back alerts to see if there are any bacterial infection. And this is an important problem because what we see is that when we collect cord blood from cesarean delivery, it's very easy to have a sterile collection. You can easily clean the umbilical cord and make sure you have a sterile collection. This is less easy with a vaginal collection. When the placenta is still in utero, in a vaginal delivery, and the cord blood is hanging, and you then try to keep it clean, then there is a higher risk of infection. Around 10% is my impression. So we have a 0% risk of infection in cord blood because there it's very easy to clean it, to keep it sterile, but it's less easy to have 100% sterile collection in a vaginal delivery. That's my impression until now. So there is work to do there too.
Yeah, there is one more question. Yeah. So there's a lot of discussion in the hall. I'll try to convey you the question.
Kind of a universal autologous transfusion that we are giving to every baby that is born. So it is a kind of autologous transfusion that we are anyway giving. But I think this practice of DCC might affect the amount of blood that we are collecting for each.
So our neonatology head, she has a comment that, we do delayed cord clamping, which is kind of an auto transfusion for the child. So if we go in a practice where we promote cord blood banking, will that affect the delayed cord clamping concept and practices?
It's a very important and a good question. I think we should not change the practice of delayed cord clamping because that's a good thing. But even after delayed cord clamping, you should not change that routine. That's a good thing for term babies. But even after, there is still more than enough blood in the placenta. So I think the two things can go well together. Delayed cord clamping, and then after, you can do the collection of cord blood, and in the majority of cases, you can have enough cord blood collection.
One more question from the hematology side.
Yeah, so in 2023, ICMR brought out this umbilical cord blood banking guidelines. So in that, most of these queries pertaining to consenting and timing, everything is very clearly addressed in there. So consent has to be taken before she goes into labor. It should not be during labor. And regarding, I think there was a question regarding the negative, as in what are the exclusion criteria. So that they also added chlamydia infection in the last 1 year, Neisseria gonorrhea in the last 1 year. Ladies who have had tattooing, all those, like you do a blood bank, a blood donor, what are the screening? So most of that is added here as well. So although those guidelines, so I was part of that guideline. So the guidelines are made for cord blood cryopreservation later, but I think the collection part is exactly the use it for transfusion or cryopreservation. So those things are already set. So maybe by going forward, it can be those also can be looked into.
Yeah.
My question to the speaker was, like, since the unit that is being collected, that would be different from an adult donor, not just in terms of HbF versus HbA, but also for the hematocrit, etc. So the processing at your end, how different it is from a regular collection?
Processing of
the collection after the unit is collected from the placenta. How do you the processing in the placenta? How is it different from a regular collection, regular blood donation?
So it is not different. So
the unit also,
yeah.
How different?
So all that is under investigation. So the question is that the cord blood that we collect for this investigational use, the processing of this cord blood, how is it different from a routine whole blood that we collect in a blood bank? So how the processing is different? If you can just share your thoughts on it.
Yes, so I'm a neonatologist. I just give the blood to the blood bank and they do their best. But what I've learned from them is that they process the blood the same way. However, it it does make sense that we should look and research, perform studies to see if there is a better way of that cord blood could need to be processed in a different way. For example, using different filters, because we don't want to. We need filters for the leukodepletion, etc. But we don't know if the adult and a cord blood need to be processed in a different way. Maybe they need a different solution to keep it better. So this is really something that needs to be looked in a more detailed way by people from the blood banks.